Segunda palestra do Dr. Riley, Back Pain Evaluation and Treatment. Dr. Riley.
Great, well, thank you. Because of some of the questions that we had earlier, at the end of the talk, I'm going to show you some pictures of Hopkins and the medical school, and sort of go through again what it's like to be a student there. So I'm going to talk to you about the evaluation and treatment of back pain. Those are my disclosures. So back pain is a major reason for emergency room visits. It's one of the major reasons for emergency room visits, and a major cause of disability over the age of 40. It has a prevalence of about 80% over the lifetime of people. There's chronic back pain of 10 to 20% of the population, and the costs are fairly high in the United States, about $50 billion a year. So this is the normal spine, and the normal spine has three curves. It has a cervical curve, it's lordotic, thoracic curve, and a lumbar curve. And there's the bones, the vertebral bodies, the discs, and then the spinal column, and then the nerve roots that exit the spinal column. Similar, this is a diagram similar to what you saw this morning. With the aging spine, there's disc degeneration, seen here, arthritis in the facet joints here, and you can develop osteoporosis, or weakening of the structure of the bones. This is a myelogram showing someone who has disc bulging, narrowing of the disc space and disc bulging, and compression of the nerves and the narrowing of the spinal column. So with disc degeneration is a normal process with aging. It's like getting gray hair or wrinkles. It begins in the 20s. There's decreased water content in the discs that leads to the loss of the height and the change in the behavior of the disc, leading to arthritis of the facet joints. And it's very common. It occurs in 80% of people over the age of 55. Facet arthritis, these are the facet joints. This is the disc. Facet arthritis begins after the degeneration of the disc itself. And it causes cartilage wear, enlargement of the joints, but it's most often painless. And it's due to overloading of the joints because of a change in the height of the disc itself. Back pain, again, is very common. 80% of us will get it at some point in our lives. It typically occurs in the second or third decade. It is equal in men and women. But there's a small percentage of people who will have chronic back pain. So only 5% of the population will have some form of chronic back pain. A small percentage of that group will need treatment. Another will tolerate it and will not seek medical care. What are the risk factors? The risk factors to getting disc degeneration and back pain include smoking. It's due to the nicotine that interferes with the blood supply to the disc. Lifting or vibrating, so heavy stress on the disc from either driving for long distances or lifting and putting lots of stress on the disc. A sedentary lifestyle, and then also back pain occurs as quite frequently in pregnancy. Due to the change in the mechanics of the body during pregnancy. And this is usually temporary and will improve after delivery. Causes of back pain, and in terms of acute back pain, can be strained muscles from doing something unusual, disc degeneration or disc herniation, facet arthritis. In most cases, though, we don't really know why it happens. So most of the time it's an unknown cause. Typically, back pain is short-lived, so it only lasts in most people for about a week. A small percentage lasts more than that, or it lasts up to 3 months. 95% is resolved in 3 months. But there's this small chronic back pain group, and that group actually uses most of the resources and it costs the most to society. In terms of treatment, the initial treatment is just a short duration of bed rest. That would be less, 1 day or less, if you can avoid lying in bed. A non-steroidal anti-inflammatory medication, both to relieve pain and decrease inflammation. Then gradual mobilization, and then resuming cardiovascular fitness, trying to get into a better routine, a better physical routine. There's been a study of patients who were actually recruits to the Army who had back pain. And one group was given an order to stay in bed for a week. Another was given an order to get up and walk around. The people who got up and walked around had less back pain and had their back pain resolved quicker than the group that was asked to stay in bed. So it's important to be as active as possible, as soon as possible when you have back pain. So when do people typically see a doctor? Typically, you shouldn't see a doctor any earlier than about 1 to 2 weeks, because most of it will resolve or begin to get better within that period of time. If patients have weakness in their legs or leg pain that radiates below their knees, that's often an indication that they have sciatica, which we talked about. And that could be an indication for seeing a patient, seeing a doctor. They have the loss of the control of their bowel or bladder. They have fevers or chills. If they have cancer history, or if they've had trauma, fallen down stairs, been in a motor vehicle accident, have the potential to have a fracture, that would be another reason to see a doctor. So who should you see? You definitely shouldn't see me. This is me about to do an operation. I have my headlight on, my loops on, I'm ready to go. I mean, it's going to be a good day for me because I get to operate. But you shouldn't see me because you're not going to need me most of the time. Okay? You need to see a general practitioner, a family doctor, but you definitely don't want to see a specialist like me because I'm not someone you need to see to begin with. What will someone do when they see someone with back pain? First of all, they'll take a history and they'll ask about how it started, what makes it better and worse, do you have any history of cancer, other things like that. Do you have any history of cancer or anything of sort of thing like that? They'll do a physical examination. Okay, they'll check your range of motion. They'll go through the physical examination of what you should do when you see somebody with back pain. And then they'll begin treatment. So back pain can be actually a difficult diagnosis to make and to distinguish between different sorts of pain that originates in the back, because there's a variety of different things that can cause back pain. The patterns of pain are not specific. Different things can be happening, 2 different things or 3 different things can be happening at the same time, so it's important to distinguish what pain is coming from. And the examination signs are often not specific. It's not specific to one thing. So we're going to kind of go through the different types of things that you need to think about and look at while you're examining somebody with back pain. And so the history is critical. That's really when you make get most of the information that you need to make a decision. The physical examination really refines your understanding of the problem. But you generally will have narrowed things down before you actually do a physical examination. And then the radiographic x-rays and other types of studies can be done to confirm the diagnosis, but they're really not necessary in most instances. So it's important to have a reason to get the x-rays before you order them, to be asking a specific question that's answered by the x-rays. So, the differential diagnosis is there could be something wrong with the spine. They can have spondylosis, arthritis of the spine, a radiculopathy, pressure on the nerve root. We discussed that earlier this morning, right? That causes leg pain and buttock pain, numbness or tingling. You can have spinal stenosis, which is a condition where the spinal canal is narrowed in the lumbar spine. It can cause leg weakness or numbness or a vague feeling like you have to sit down or bend over. Or it can be a combination of several of these. In terms of non-spine issues that can cause back pain, you can have hip arthritis, and people will have hip arthritis and back arthritis almost at the same time in their 50s and 60s. Or you can have sacroiliac joint arthritis. Now this is a very rare condition, and I usually think of this as something that you very rarely see, but you need to think about. But it's not really a common diagnosis to make. So in terms of the history, when did it start? Did they wake up with did you wake up with it? Did you fall down the stairs? Did you garden and move a lot of dirt? Or move into a new apartment or move a lot of books? What was the cause? Was there a specific cause? Has it changed? Has it changed over time? Did it feel a certain way in the beginning and now feels a different way now? What makes it better or worse? And then what things can you do or can you not do? Because that can give you important information. And then where is it? Where is it now? Where was it before? Does it change over the course of the day or with different activities? So I'm first going to talk to you about hip arthritis and hip pain and how that's different than back pain and how you make that diagnosis. Okay? So hip pain most commonly is in the groin or in the buttock. It tends to center around the hip on one side. It can extend into the front of the thigh, but does not go below the knee. And that's the type of symptoms that people will have with hip pain. In terms of things that make it better or worse, getting up from a chair really requires a lot of force on the hip joint, so that makes people hurt. Getting out of or into a car, going up stairs or a curb on a street, crossing your legs, tying your shoes, and actually it can improve with activity. So people who have hip pain may say they get up, they stand up from the chair, they'll suddenly have pain, they'll have to adjust themselves, they'll walk a couple steps, and then they'll feel better. So that can be a sign that someone has arthritis of their hip and not back pain. So lumbar spondylosis, in which arthritis of your back, that can occur, usually occurs in the middle of the back, and then goes into the sacrum, goes down into both sides of your back, into the buttock. It's usually, in terms of problems with the facet joint, it's worse with standing, extension, or bending to the sides. Thank you. It's better if you bend forward or sit so that you're taking pressure off of those joints. And it can't radiate into the groin and testicles in severe cases. So it can have some component that's similar to hip pain. Okay? In terms of the disc, you load the disc when you sit, and you load the disc when you bend forward. It typically is better with standing. When you drive a car, you're sitting, and you're vibrating. So people will notice, especially with disc problems, that sitting in a car is worse than sitting in a chair. And one of the reasons it is the disc material's harmonic. The thing that makes it move the most is the same as the harmonic of a car engine. So it makes the disc move back and forth the most, and it can irritate the nerves or irritate around the disc or that run down the leg. This is the other thing that you can have in your back, spinal stenosis. So that's narrowing of the tunnel where the nerves run, narrowing of the spinal canal in the lumbar spine, in your lower back. That could cause pain down the lateral aspect of your legs. It could be worse with prolonged standing or walking. It's better with sitting. And it can have numbness or tingling or vague weakness in your legs. And often when someone comes in with their friend or their spouse, they will describe that the person that you're seeing will lean further forward the longer they walk. And they will tell that person to stop, to stand up straight while they're walking. And they'll have noticed over the last several months or years that they bend forward when they walk, and they think that the problem is that they're bending forward and it's their posture. But in reality, they're bending forward so they can walk, because they're taking pressure and making more space for their nerves. In this condition, there's something called the shopping cart sign, where if somebody goes shopping, they'll lean over a shopping cart so they can make more space for their nerves and walk longer distances. So you can ask them what they do in a store with a shopping cart. Do they lean over the shopping cart? It allows them to stand up for longer times and walk further. Then there's radicular pain. We talked about that earlier today. It extends typically below the knee. It's associated with numbness or tingling or weakness or reflex changes, and you were shown some pictures of what those patterns are. And that can either be due to the facet, as we discussed, from arthritis in the facet, or a cyst in the facet, or a disc herniation. So SI joint pain, as I told you, is very rare. It's really a diagnosis of exclusion. Most people who are told that they have facet or have SI joint problems actually have spinal stenosis. They're told that they have another condition. But it's commonly spinal stenosis or hip arthritis that they have. It's more common in people who have an inflammatory condition, like ankylosing spondylitis. There's certain types of arthritis that cause inflammation of joints and inflammation of ligaments. And one of the most common causes of SI joint pain is something called ankylosing spondylitis, which leads to bony fusions of different joints in the spine. It typically starts in the sacroiliac joint. So early on, people will complain of that, and it's important to think about that diagnosis when you are seeing somebody who you think has SI joint pain. Okay? Typically, it's over the SI joint. It's a little bit more, it can go into the proximal thigh, radiate into the proximal thigh, and can be painful with sitting, external rotation of the hip, and weight bearing on that particular side. So here's some general rules of thumb when you're seeing anybody, okay? When you're doing an exam, you want them undressed. You don't want to compromise your ability to examine them, okay? You want to examine both sides. The advantage of being an orthopedic surgeon is you have two of everything. You have two arms, two legs. You have just one spine, but you should examine all the joints, one side to the other. And you should look at the joints above and below the joint that you think is being bothered, because it sometimes can radiate up or down, in particular down from one joint to the other. And you want to do a careful neurologic exam. So here's the spine exam. First, you want to do range of motion, forward bending, extension. And forward bending can cause more pain with disc problems, extension with facet problems. You want to just sort of see what their range of motion is. Sometimes people with conditions that fuse the spine, like ankylosing spondylitis, aren't able to really get their hands very close to their feet or ankles. So it's important to note that, okay, because that can be a clue that somebody has a fused spine. Then you want to do side bending and rotation to check that. Typically, rotation can be affected by muscles, so that can, and side bending can as well, and the location will be over a muscle group, and not necessarily over the middle of the spine in a specific area. Here again are the different dermatomes, and you went over those before. Okay. So here's the hip exam. Hip exam, you want to look and see if they have a harmonious walk. So do they limp? Does their hip, do they look like they're kind of wobbling when they walk? Okay. Then you want to look at what they do when they stand on one leg. If someone has bad arthritis on one leg, if you ask them to stand on one leg, their pelvis will drop. They usually drop towards the affected side because they're trying to take weight off of that joint. Okay? So if you ask somebody to stand on one leg and then on the other, they may have pain. If they have arthritis, if they stand on the affected leg. If you ask them to hop, they may not be able to do that. And they may lean over. Okay? They may lean over and not be able to stand with a level pelvis. Most people, if they stand on one leg, their pelvis will stay parallel to the floor. If they have a problem with their hip, it'll drop. So we'll look at that. Okay? And this is the Trendelenburg test. Okay? So this person's left leg on the left is negative, on the right is positive. You can see how they dip it down. Okay? Then you want to check range of motion. You want to check it one side to the next. They should be symmetric. They should be the same on both sides. And you want to check internal and external rotation. So abduction, bring the leg out, bring the leg in, twist it out, and compare one side to the other, and see if it causes pain. All right? You want to check leg lengths as well, and check their strength. Here's the SI joint examination. So it can hurt when you walk, when you stand on one leg. Typically it's right over the SI joint. It's more medial, it's more on this side, right here, as opposed to lateral. So it's right and more medial over the joint. This is one test to test the SI joint. In this test, you're testing this joint here by stabilizing it, by keeping it from the hip from moving, and then using this leg as a fulcrum to move the right SI joint. Here's another one. On this test, you're testing this joint. So the test is you're testing whether there's pain on this side. This is just being used as a way of putting stress on the right SI joint. And then there's distraction, you push on both. Okay? That can be useful also with fractures. So treatment, this is treatment mostly for back pain, okay, is nonsteroidals, a short course of nonsteroidal anti-inflammatory medications or muscle relaxants. Very short course of narcotics if they're necessary, and in most instances they're not necessary, but just for a very short period of time. Back exercises, begin them as soon as possible, and I encourage people to continue to do them on a daily basis for the rest of their lives. And then encourage activity. Don't have someone lie in bed because they hurt. Tell them that they'll feel better quicker if they move around. So you want to stay active in terms of prevention. You want to stop smoking. You want to learn proper lifting techniques, and this is something that the physical therapist can teach a person. You want to do daily back exercises. And then if you develop intermittent back pain, help the patient by telling them what would be an appropriate short-term protocol for them to take nonsteroidal anti-inflammatory medications, how much to take and how long to take them. Typically takes about 2 weeks of taking a nonsteroidal anti-inflammatory medication on a daily basis for the pain to get better. So you want to encourage them to continue to take it even if they don't feel better for about 2 weeks. So what are the indications for x-rays? Okay, the indications for x-rays, as we said, are a tumor, a history of tumor, like breast cancer, colon cancer, lung cancer. Those people, you need to get x-rays right away. You need a history of an infection or fevers or chills, fracture, and then age greater than 55. But typically, in people who don't have any of those risk factors, you want to wait at least 6 weeks, or about 6 weeks. Here's an MRI. This is an MRI scan that shows someone with arthritis in their back and spinal stenosis. They have a little facet joint cyst here. They have a slip, so one vertebrae is moved forward on the other. And they probably have buttocks.